Θα κάνω την παρουσίαση στα αγγλικά πρώτα και μετά στα ελληνικά. It's with great pleasure to introduce Dr. and Professor Dr. Nir Peled. He's an example of a physician scientist who has more than one subspecialties in lung disease, and he's the director of the thoracic early detection and treatment for lung cancer at the very world-class Sheba University. Welcome.
Thank you for this invitation. It's always a pleasure to be in Athens again. Thank you. And what I've learned this morning is that if you say Kalimera, it always works. So Kalimera for you. And always, and also I've learned that even you see slides in Greek, you can know what it is about. So my slides will be in English. Those are my disclosures. And I would like to start with kind of a case presentation, and the focus would be biomarkers in IO, and specifically not only TMB. I would like to cover different types of biomarkers and to see how it can assist us in our next step when we would have some clinical discussions about patients. So just to share with you a very interesting case that came on April 2017. So it's almost 2 years ago. So this lady, actually, she's 57 years old, female, 30 PEC years. You see her nodule here on the left upper side. She was EGFR all-cross negative. PD-L1 was above 75%. And on her liquid biopsy, because we did not have tissue analysis for next generation sequence, we performed a liquid biopsy that showed a BRAF rare mutation on the 751 location. So April 2017, so the question would be, what would be your treatment decision? Pembro first line, combo, chemo, pembro, even though it was not, at the moment, at that time, was not approved, chemo plus minus bevacizumab, or going for this rare BRAF mutation. So she got pembro 3 cycles because this is what was approved at that time. She had a general improvement, but in addition, we also radiated some bone metastases, so maybe it was just secondary to the pain control. And then after the 4th cycle of pembrolizumab, she has a right pelvic pain. You see, I hope you can see those bone metastases here, but we know that lytic lesions can occur even though it was, the metastasis was previously existing. But she also had some tiny nodules on the right line. So it can be also kind of a pseudo-progression, 4 cycles of pembro. She was kind of generally okay, but she does have some bone pain. So it's kind of an unclear situation. And the dilemma was like that. So should we continue pembro and wait? That makes sense. Should we switch to second line? Because she's kind of progressing. So what do we have in the second line options? For example, chemo without pembrolizumab. Should we continue pembro and add chemo on top of the pembrolizumab, even though there was no evidence to do that? But let's assume she's kind of a combo up front, but she missed the chemo cycles of the beginning. Or maybe we do have, a lot of experience that we switch patients to nivo-ipi as a second line, even though the evidence is kind of weak, but we can do some extrapolation sometime. So that was the options. And what we've done is that we continued pembro and added chemo on top of the pembrolizumab that she got previously. So she had a very fast clinical improvement. Of course, there is no data to support this strategy, but she did have an improvement for, I would say, a certain amount of time, as she was doing well for 6 or 7 months. However, she progressed later on. So this is kind of a case that would raise a question: can we do it in a more evidence-based manner, or can we have some biomarkers to lead us if we are doing it on the right way? So what are the most significant recent breakthroughs in lung cancer in my perspective? And we will do it quick, just in sake of time. So first of all, I think, I'm a fan of screening. So, and actually we know that the Nelson study is positive, and the evidence is no longer a question, and there is a mortality reduction significant, so this is the way, time to implement. We know to predict response to therapy, genomic or proteomic. IO in first, second, and consolidation phases is here. We know to penetrate the brain today with TKIs. We know to uncover resistant mechanisms, like it was previously shown in the RCC slide. If you've seen the evolution of the tumor, was really kind of a good example. And circulating tumor DNA is always a very good and easy, in some ways, a way to analysis disease progression. What do we have in IO-related evidence? So first of all, we have pembro plus minus chemo for non-small cell lung cancer approved. The same for atezolizumab, also approved for adeno. We have chemo-atezo in small cell lung cancer. We have all the IO which are here for second line approved. We have durva as a consolidation. And we know that there is a low efficacy of IO in patients with a classical driver mutation, even though there are some reports of atezo, etc. But in general, I would say you have a driver, this is not the way for IO in general perspective. But we also know that when we combine two types of IOs, CTLA-4 and PD-1 or PD-L1, even though the Pacific was negative, the durva-tremi was negative, but we do have a higher response rate when we combine those drugs, especially if we combine the EP on top of it, and especially with the high TMB. So TMB is a biomarker to use, and we know that it was active, even though the recent data was not a significant study, but we do see signals in small cell lung cancer on the second line. So which is the best predictive biomarker for IO? So previously the summary was that PD-L1 is not the single best biomarker. So the question is it PD-L1? Is it TMB? Is it lack of EGFR ALK-ROS driver mutation? Or should we say we do not need biomarkers anymore? We can go for all comers as much as we wish. And this is a question that is coming up every other day nowadays. So I will let you answer to yourself, but just kind of a quick hand-raising questions. Who thinks that the best predictive biomarker is PD-L1 among those four? Okay. Who thinks TMB is the best biomarker? Okay. 3. No, only one. Let's assume we have only one. A lack of EGFR ALK-ROS. I think this is a negative biomarker, so I think it's a very strong one. And who thinks that he does not need a biomarker to go for IO? Okay. Okay, so Second question. Among these, let's assume you have a patient stepping into your clinic with a adeno or squam or whatever that has a PD-L1 above 50%. Let's say 60, 70, 90%. What would convince you to go for pembro alone without chemo? Actually, we can say all do not need chemo because they have a PD-L1 above 50%. And adenocarcinoma case, a TMB above 10 can get IO. So maybe this is, and especially if it has a PD-L1 above 50%. Or would you say there is a low disease burden, I have no rash, I can start with pembrolizumab alone? So this is a questions that I'm sure are at your daily life. Do you have combo approved in Greek? I mean combo IO, no. So you do not have much of those questions. But we do, because we do, it is approved, reimbursed, and it is a real question. Okay, so what else do we know? We know that the more PD-L1 you have, the more efficacy you would see on the on those curves. We know those paradigm. It was shown previously that TMB, bless you, is a good biomarker, but we also know that TMB is not a PD-L1. So this is kind of a different game yard, and we need those two biomarkers because there is no single biomarker actually. But we also get some clues like this one, as you see here. This is TMB. Green is TMB high, and orange is TMB low. So you see those patients with a classical driver mutation like EGFR, ALK, ROS1, they are on the left side of the slide, which means they have a low TMB. Patients with kind of a nasty mutation like BRAF V600E, KRAS patients, BRCA, those with DNA repair abnormalities, have more of high TMB. So you can also get some signals from this perspective. So let's move also to this blueprint analysis, and focusing on the differences between those PD-L1 biomarkers. Because we have so many biomarkers, we have few drugs, and only one is approved as a single agent for first line. What we have learned when we compare those different biomarkers related to the drug, 4 drugs here, we know that they are almost the same. We know that this atezo PD-L1 staining does have a higher cut staining. So it means that if you do get a negative PD-L1 on the atezo or Roche-related biomarker, it might be that it would get a higher score with the other biomarkers when you stain the tumor. When we stain the lymphocytes, we get the same analysis. So now you have a discussion with your pathologist. You ask your pathologist, do you speak with the pathologist or just write emails? Okay, so if you are available to pick up the phone and discuss it with the pathologist, so he would tell or she would tell you that those are the toolbox I have: immunohistochemistry, a PCR, FISH testing, and in some institutes, they do have also a next-generation sequence based on the Illumina or on other platforms like Iron Torrent. And those are the biomarkers that you would like to get, PD-L1, EGFR, ALK, ROS, etc. And also, you would like to get a TMB. So the question would be, who pays, and what is the validation, and how accurate it would be? So, you know, FISH is not an easy task. It's always after lunch, a dark room, and you see those pathologists with, you know, black eyes. It's not because they are tired, just because they do too many FISH testing. But if we go for the NGS platform, you see that it would cover those point mutations very easily. but the skip mutation of c-Met or fusions might be missed by NGS. When we move to hybrid capture NGS like the Foundation One or Cancer Select or other platforms, which are not available very easily because they are very expensive and it would be difficult to send tissue to them, you would cover most of those issues, and you will also have a valid TMB score, because the TMB score is not an easy task, and it depends on how many genes you are investigating, how deep you would go on the sequence, and the algorithm, of course. So just kind of a quick question. How many of you do have experience with Foundation Medicine results? Okay, so not many. But this is a true tool, and I hope it would be commercialized in the kits very quickly in the next few years. So those are the tests that we have. So what are the main challenges when we go and deal with our lung cancer patients? So first of all, we have diagnostic challenges. Sample size is tiny. Turnaround time is too long. You wish to start as soon as possible. Now, if you are going with combo, it might be kind of a, fast go. I mean, because you do not have, in some perspective, weight, but it's not always easy. PD-L1 implementation, should we continue with PD-L1 implementation or not? Because if we go for combo, why should we focus on PD-L1? My personal perspective is that we do need PD-L1, even though that, let's assume that combo would be the way to go, but the question, what combo are we willing to do? Should we go IO one day? Maybe PD-L1 plus TMB is the best biomarker, or do we want to go for IO chemo? The PD-L1 staining would give you an insight of how soon can we stop chemo after you get the immediate response. So I use PD-L1 also for my combo patients. Of course, multiplex testing is important. It's not been implemented in many centers. And of course, TMB standardization is really important because you would like to get a valid TMB score. On the therapeutical arena, of course, we have patient selection is always a dilemma. How do you select patients is not how do you select your patients, how do you select treatment, it means. And one of the progression, and I would say issues, is that patients do have, and also physicians, do have high motivation to treat with IO. Nobody is happy with EGFR mutation nowadays, or ALK mutation. So if you would tell to a patient, let's say 4 or 5 years ago, you are an EGFR positive, everybody was happy. What happens today? They are not happy because they want to be in clinical trials and all this stuff. So they are not willing to do those fancy gene analysis in order to be diagnosed with a driver mutation. And this is actually a big issue because we do miss many patients with driver mutation. We give them IO, they do not respond, and we are losing a lot of expenses. So, and that brings me to the Checkmate 2 to 7 discussions that we will go into a deeper discussion as it was promised previously. So just in a nutshell, so you have this Checkmate 2 to 7 complex design, but let's focus on PD-L1 positive or negative, Nivo-Ipi versus chemo versus Nivo, but I would like to focus on different paradigm. And also before we go forward, the TMB cutoff for discrimination between groups was chosen as 10 mutation per megabyte of DNA based on the Foundation Medicine platform. And the reason is because of the ROC curves. And I would say that the reason is mainly because 10 is easy to remember. But they convinced us that 10 is a good cutoff measure. When we go into the high and low TMB split of the patients, you see that the PD-L1 staining between those groups was equal. So this is kind of a fair comparison. So what do we see? That we see this is the PFS of all randomized patients. You see here, nivo-ipi versus chemo, even though it's crossed here, and those patients with evaluable TMB. So this is the comparison that we should go for. When we focus on response rate, and I think it's really important, sometimes we do need a fast response. We have patients that cannot tolerate chemo. We have patients with an aggressive disease, and you would like to get a fast response. So this is the comparisons. We have nivo-ipi. You see here, complete response is this 3.6%, a partial response 41%, in total 45%, like Pembro single agent for strong PD-L1 positive. So it means that there is a rule, a number that goes with IO only. And for chemo, we have about 27%, and no. There's maybe a complete responder here, 0.6. So this is chemo alone. Duration of response was much longer with nivo-ipi, and the figure talks to itself. Depth of response was also much deeper with a combo for those patients with TMB above 10 mutation per megabyte. So including complete responders, and as you see here, the depth is much better versus chemo alone. And how the PFS looks like, again, it looks very good for nivo-ipi versus chemo, but I would say that the real question is not versus chemo, because none of our patients will get chemo alone for first line once it will be reimbursed. But it gives us an insight that this is a valid comparator. When we go to overall survival, so the hazard ratio is not good enough in order to get an approval, but there is a trend, and we hope that the final overall survival will be shown in less than a year. So we will see what will be the final answer for those patients with TMB above 10. But we have a lot of experience with foundation results, and we have many patients with TMB much more than 16 examples. So the atezolizumab based on TMB of 16, also I think for renal as well, right? So maybe we should pick up a higher cutoff for TMB in order to show a better results here. When we go to the subgroup analysis, so we see that both squam and non-squam did have a benefit, and PD-L1 was not a discriminator. So all those patients did have a benefit. And of course, and when we base it on histology, we see both in non-squam and squam significant benefit for those nivo-ipi, and also with when we split it by PD-L1 staining, when we have it more than 1%, and this is before, so it might be that the combination of nivo plus ipi may overcome the lack of PD-L1 staining, but this is too early to show. When we focus on only PD-L1 and TMB, PD-L1 and TMB, so the more positive markers you would have, the better response or outcome you would expect to see. Safety, actually, it was not a big issue compared to chemo, and my own experience with patients with nivo-ipi, and we gather more than 50, 60 patients with nivo-ipi in different lung-related diseases, both small cell and also non-small cell lung cancer on the second line. We do not have much of issues with this combination of nivo-3, ipi-1. It's really very well tolerable, and we didn't see much of expected toxicities, I would say. So the adverse events, as you see here, this is the nivo-ipi, and this is grade 3-4, not many of grade 4 toxicities, and that was for the IO. When we go for a new comparison, nivo plus chemo versus chemo, kind of a combo first line, IO chemo, you would see that there is an advantage for adding nivo to chemotherapy for patients with high TMB. For patients without a TMB, there is no advantage of adding nivolumab to chemotherapy, so there is another insight or another suggestion to combine between TMB and nivolumab therapy. And again, here, what you see here, nivo plus chemo versus nivo plus ipi with patients with TMB. So you see here, once you do have a high TMB and negative PD-L1, nivo-ipi is better than nivo-chemo. And just to confuse you with another Kaplan-Meier curves, but at least it looks really good, when you do have high TMB, and the PD-L1 is above 1%, so nivo-ipi is the preferred algorithm. And again, too many comparison, nivo-chemo, nivo-ipi. Again, when you do have a high TMB and a positive PD-L1, so you would go for this combination again.
Dear Professor Peled, could you summarize?
I'm completing.
Thank
yes.
you.
So just to summarize this 2 to 7 results, so high TMB predicts benefit from nivo and nivo-ipi, unrelated to PD-L1, and of course, 2 are better than 1 in those circumstances. I will skip this PD-L1 and STK11 KRAS mutation, and my take-home message is IO is a valid therapeutic option, of course, pending upon the final approvals, and PD-L1, TMB, and drivers are predictors for IO, and KRAS STK11, I did not present it, but you can go to Cancer Discovery, are negative predictors for immunotherapy. This is really, I think I would say, an important factor. And again, 2, you can choose different 2s, are better than 1. So thank you, and if we have time for questions, we can discuss.
Έχουμε χρόνο για 1 ή 2 ερωτήσεις. Κάποιος από το ακροατήριο.
So, Professor Peled, do you use in everyday clinical practice TMB, and is it safe to use? Because, you know, there is also the problem of cost of drugs. And if we use in which line? In first line, second line?
Normally, if we do have TMB as part of the Foundation Medicine score. So if we send the tissue to Foundation Medicine and it is covered by some of the private insurances in our country, we do get TMB anyway. Is it safe? It is safe because it's part of the report, so it is not requiring any more, I would say, extra fees or something like this. We also push the TMB harmonization by different platforms based on the ion torrent gene analysis, and we do get local TMBs as well if we provide a multiplex TMB. I'm not sure that the values can be compared at the moment between the different platforms. So I wouldn't say that it would be okay to count on the ion torrent-based TMB for taking decisions.
Yes. Microphone, please.
In the survival curves, we see an early... We always worry about immunotherapy with early drop of the survival curves. And the PFS, also a little bit on the overall survival, mostly on the PFS. is there a subtype that has been identified that may not respond well to the combination treatment despite of the TMB? Is it perhaps the group between 10 and 15, let's say, or 10 and 14?
Yeah, I think, the PFS is the main, I would say, enemy for going with IO alone. I definitely agree that time to response is important in order to get better results of patients. And if we do see a high TMB, I think it's a good biomarker for IO. I think this is a strong biomarker to go for that if you have it very early. But we do have labeling issues to go for the first time at the moment. We need
always worry when a continuous variable becomes on and off, yes or no.
Say it again?
We always worry when a continuous variable is translated
I agree.
into
Yeah, that's true. Yeah.
What Sophia says, I would like the opinion of Sophia. Given the result that you showed us with a combination of IO plus chemo, you would need TMB to use IO plus chemo in the first line?
Good question. I think that the results are clear regarding the combination of chemotherapy plus immunotherapy. And speaking of, let's say, patients who have high PD-L1, PD-L1 more than 1%, then there we have a PFS benefit and OS benefit when we use the combination of pembrolizumab plus chemotherapy. However, in patients who have less than 1% PD-L1, then with the combination of chemotherapy with pembrolizumab, we showed that patients have PFS OS benefit but do not have PFS benefit. In those patients, I'm not sure whether TMB could help me to decide, because in the first case, I have, let's say that I have a patient who has less than 1% PD-L1. Then if I use the combination of pembrolizumab plus chemotherapy, then I will have a survival benefit. If I use a combination of IO, I will have a PFS benefit, but the survival benefit is not clear. So I'm not quite sure, actually. Yeah. I would go with the PFS benefit, with the OS benefit, I'm sorry, unless patient wouldn't be delighted if he had chemotherapy. In those patients, I think that we could spare chemotherapy and use IO. And for those patients, we also have the opportunity to add chemotherapy in the second line.
Okay.
So Professor Peled, to which extent you actually look at the report and screen for genes that have been mutated that may have potential immunosuppressive function, and therefore that makes you say, I'm going to give this guy combination as opposed to single agent?
And I think we only at the beginning of this field, and I think we do need more signatures, I would say, or panel of biomarkers to select patients from different treatment dynamics. But I also think that we are limited to the evidence at the moment, and we try to be as much as evident as possible. But the truth is that a tumor is not such a simple behavior. There is a tumor evolution, and I'm sure that we need biomarkers in order to play with the different dynamics of tumors. Let's assume that the tumor-reducing T-cell receptors, portfolio, and it might be that you need immunotherapy and chemotherapy for the beginning, and then you would like to stop the chemo in order to let the lymphocytes work better. But if we do see a signature like this STK11 and KRAS together, or a low PD-L1 staining, or a very low TMB, I wouldn't be so happy to stop the chemo very quickly. So I think those biomarkers do have some role in our art, I would say, but it's not really clear evidence at the moment.
Thank you, Professor Peled. Thank you, Professor Angelakis, for the lung cancer discussion.